A very good morning to everybody. I'm Jack Tay from Singapore, and it's my great pleasure to introduce our distinguished faculty panel today at the Focal Therapy Society Tumor Boards in Focal Therapy. Focal therapy is a highly personalized treatment where we only want to treat the focus of clinically significant cancer and preserve the patient's quality of life and functional outcomes while treating the cancer completely as well. So today we have brought together this panel of faculty where we will look into learning points of difficult cases and to see how we can actually improve our outcomes. I'm joined today by Dr. Abreu from the University of South California, Los Angeles, Dr. Peter Chiu from the Chinese University of Hong Kong, Dr. Ruben Olivares from the Cleveland Clinic, he's the director of focal therapy there, and Dr. Phillip Stricker from the St. Vincent's campus at the Garvan Institute, New South Wales, Australia. The Focal Therapy Tumor Boards is supported by the Focal Therapy Society. If you have not joined as a member and you would like to access more resources as well as see our previous episodes of Tumor Boards and Focal Therapy, please scan the QR code or go to this website. You can see our previous sessions there if you want to learn from those other faculty that have joined us before. So without further ado, I'm going to hand over to our first speaker, Dr. Abreu. Andre, please.
Dr. Tay, thank you so much for your kind invitation. Thank you for the Focal Therapy Society and for the excellent work that you are doing, educating all of us. It's a real pleasure to be here with these colleagues to discuss about focal therapy. So the first patient I selected is a 57-year-old male that was already on active surveillance with Gleason 6 in the right base and was referred to me. His PSA was 4.7. He had done some oncotype that showed low-risk prostate cancer, and he was asymptomatic with good functional in terms of erection and voiding. On follow-up, or surveillance follow-up, I ordered an MRI, and the MRI showed two mild suspicious lesions, Paredes 3, one on the right side and one in the mid of the prostate. And then you can see there on the biopsy mapping how it's tricky to biopsy medially location lesions when we go transrectally. Anyways, the results of the biopsy still showed grade group 1 prostate cancer in the right and then in the left, low volume. So this patient has low or very low risk disease. And here's the first question I would say is, should we treat these patients with focal therapy or not? Should we treat patients with low risk cancer? Then I didn't. I kept going following these patients on active surveillance. And then one of the follow-up MRI shows a new onset Paredes 4 lesion. Again, his PSA is still stable, about 4.5, 4.7 or 5. And this lesion was anterior. You can see on the 3D mapping how was the prior biopsy and how I actually prepare for the second look biopsy. And I did this biopsy transrectal. And this is another learning point or another point for conversation. Should we do transrectal biopsy or transperineal biopsy for selecting patients? Is one biopsy better than the other? Should we do the biopsy according to the energy we are using? So anyways, that was transrectal biopsy was the only way that I could do mapping for this patient that could do fusion biopsy at that time. So the results of this Paredes 4 lesion biopsy showed actually grade group 2 prostate cancer in 6 millimeters in one core only. So now with this, should this patient undergo treatment or not? He has intermediate risk disease with a visible lesion on MRI and showing Paredes 4 or showing a grade group 2. I selected for focal therapy, and this is another point of discussion. What kind of focal therapy energy modality would you do? The transperineal, transrectal, according to the lesion location. So I used the same technology that I did for biopsy actually to guide the treatment. And I did first the fusion and treat only the area focal. And then I went ahead again at the same section, of course, and did hemiablation to compensate for margins. So margins for focal therapy is also another point to discuss. On the follow-up, his PSA dropped to 2.5. it was 4.75 to 2.5. So it was 50% reduction. So I was not so happy with this PSA. And this is another learning point. How much is the PSA should drop, and how would you be happy or would be satisfied with the PSA value? Anyways, I followed this patient with MRIs, and the MRIs were negative. PSA was still rising up to 4.6, which was pretty much the baseline PSA. So based on this is the most recent MRI that was done together with that PSA, and the MRI showed no lesion at all. And now is another discussion point. Should we do biopsies for patients with negative MRI? So I did. And at this point, as I had transperineal biopsies mapping available, I did 3D mapping biopsy, a biopsy systematic, including the areas that were treated before. And on one of the systematic biopsies, in the left side, actually the left transition zone, showed grade group 2 again. And now we have disease in the left transition zone with 9 millimeters, grade group 2, and cribiform. So it's another point of discussion. Should we treat patients with cribiform with focal therapy or not? So I decided to go ahead and to do. So I imported all this information, the 3D mapping of the prostate. Again, the importance of having the 3D mapping so you know exactly where to treat. And I imported all of this to the new cryoablation, repeat cryoablation. And you can see there that this is the core that is positive. Now I'm doing focal cryoablation based on the 3D mapping biopsy that I did. Okay, I took all the biopsy information and I'm now doing the cryoablation because I knew exactly where the lesion was. By mapping, not by MRI lesions, MRI was negative. I was able to superimpose the cryoprobe, and I did the treatment over there. I compensated for margin, so I treated a larger area than actually showing on the biopsy only because MRI was not guiding me. And this is the final aspect. After this is the repeat cryo. This patient, 2 months later, he came with some double flow and dribbling, and I checked, he had a meatus stricture. I dilated in office. That was the only complaint, the only complication this patient had. And now we are 2 years out. This patient's PSA is 0.09 with a negative MRI. He is continent, he is potent, he used Viagra as needed, and he is happy with a good quality of life. I think that was overall that brought for us to discuss. Thank you.
Thank you, Andre. That was a really good case. And I think you raised a number of learning points that are along the way. Let me just ask you, Andre, and maybe I'll ask the rest of the faculty as well. You mentioned doing a transrectal biopsy for this patient, and I think subsequently a transperineal biopsy was done. So I also noticed, very interestingly, this patient was initially on active surveillance, and when they progressed, you did focal therapy for them. So in a way, trying to keep the patient on surveillance and away from radical therapy. Do you think that would transform the way that you do your surveillance biopsies? Would you move towards transperineal for surveillance biopsies if you're going to be doing focal therapy treatments transperineal, or would you just rebiopsy them?
Very good question. One is I completely switched over to transperineal biopsy for several reasons. I do all of them under local anesthesia in clinic. But to answer your question specifically, if the patient is on active surveillance, should you switch from transrectal to transperineal biopsy? There are 2 manuscripts that I know showing that patients on surveillance, with especially those with discrepant outcomes on biopsy comparing to the MRI, when they undergo transperineal biopsy, they usually have upgrade on the Gleason group, because transperineal biopsy would better sampling these patients. So to answer your question straight, yes, I would switch over from transrectal to transperineal on active surveillance, not only because of antibiotics and all of this, but also because of cancer detection.
Okay, any comments from the other faculty, perhaps Ruben or Peter want to weigh in?
No, I agree. I just want to mention that I would say that the location of the spot concerning from the MRI must play a big role. I know a lot of colleagues that do wonderful transrectal biopsy, but in the focal therapy world, most of the patients were going to be very guided by the MRI, by the image. So if the image is anteriorly, I would suggest move to transperineally. And also, in our clinical practice, 1 out of 2 patients that is coming looking for focal treatment, we have to repeat biopsy. So I feel more comfortable doing a transperineal prostate biopsy, reducing the risk of infection.
Yeah, look, from an Australian perspective and from my own, we haven't done a transrectal biopsy in my practice for over 20 years. And so it's pretty well the gold standard now in Australia. And I was recently at the focal meeting over in Chicago, and I also noticed that the tendency for people who offer focal therapy to go to transperineal as their gold standard has become pretty well universal. But I probably would make the point that you have to decide on a template. I don't think you need to do 5mm biopsies. I think you need to have a template which is either the European or the Basel template, one of the two. And but I think that for many reasons, not only the safety, but in particular, this group of people who are on active surveillance, they make ideal focal therapy cases because you've monitored them for such a long time. You know they don't seem to have a multifocal problem, and so you feel more comfortable with offering them focal therapy. So, yeah, look, it sounds like a nice case, and he's got a good outcome.
Peter, how about you? Do you do transrectal biopsy still, or are you moving to transperineal? Do you, like Ruben suggests, select based on the location?
Hi, Jack. Thanks. We actually changed to transperineal biopsy like since 4 years ago, and in Hong Kong, in a small city, we actually changed from transrectal to transperineal for the whole of Hong Kong. Almost like 90% of the transition in the past like 3 years. So it's actually a little bit uncomfortable for me to look at previous transrectal mapping, which made it a little difficult to assess how we're going to plan for it. I just have a short comment to the experts here, like including 3 other experts here, well, 4 experts here. With the location of the tumor, of the initially treated tumor on the right anterior, just next to the prostate urethra, be a concern when we're using the cryo, because for this case, if it's my patient, I might be a little cautious in using cryo. Of course, it is still feasible. I'm not sure whether, from my expertise, would that be posing a challenge because of urethral warmer, and sometimes I actually have a couple of cases with local recurrence like after cryo. So I would like to seek your opinion too.
I'm not sure I completely understood, but few things. One interesting thing on this patient is that you can see the evolution of the technique, the evolution of the technology, and the evolution of the understanding of the disease and how we approach things. This case goes back to 7 years ago or so, when I started doing his follow-up biopsies, and at that time, transperineal biopsies were not really readily available with fusion. Was only random biopsy. So as opposed to do, and this would be even today, if you will do a transperineal biopsy or an MRI fusion biopsy transrectal, I would do an MRI fusion biopsy transrectal, as opposed to do a sampling randomly non-fusion transperineal. So at that time, that was what I had. And also for the intraoperative treatment, you saw that from the beginning, I used only the mapping to guide, but afterwards, I was able to actually predict the ice balls as the technology became available as well. So this case shows several aspects on this. And if I understood your question, if cryoablation would treat appropriately, I would say yes. Cryoablation has been there for long. Is one of the most studied energy technologies available. And if you deliver cryoablation appropriately to a spot, I'm very confident that the spot will kill. I mean, the cancer will be killed. The problem are, escape lesions, other lesions, contralateral side, like in this patient. But if the cryoablation hits a spot, that spot is gone.
Andre, I think it was alluded to by, I think, Peter, how far from the urethra. I mean, being a cryo user as well, I was trained to put a warming catheter inside, and that means that around the urethra, maybe about 5 millimeters, we don't ablate as well. So would you avoid treating with cryo such patients? How near does the lesion get, or your margin? How near does it get to the urethra before you feel uncomfortable with cryo?
This is a very good question. If the lesion is very close to the urethra, then you have two options. You turn off the warming catheter, right? Because you're not ablating the urethra completely, so this patient should still be ablated, well, should have a good treatment. Or you can find other treatments such as vapor or TUSA or IRE or laser. Again, not necessarily one tool, not necessarily one energy for everything. In this case, as shown, the lesions were properly ablated. They were not on top of the urethra, very close. But there are some tricks that you can address.
Right. And how about for the rest of the faculty? Are you concerned with treating lesions near the urethra? And what kind of margin do you aim to treat the lesion with?
So I think the consensus is that the energy source that you use, no matter which energy source you use, has its advantages and limitations. And I think the most important thing is that you become good at your energy source, and then try and use other energy sources to where you don't feel that your particular expertise is not covering that particular area. My particular expertise is more in IRE, and the one advantage of IRE in the para-urethral area is that you can put the urethra literally in the middle of the field, and whilst you will get edema, you won't get any stricture or sloughing. So there is an advantage para-urethral of IRE over cryo, but I know some cryo experts who modify their technique and go fairly close to the urethra with good results. So I'm not saying one's better than the other, but I think if you had a choice between them and you're right next to urethra, I think I'd probably go for an IRE type of treatment than cryo. But, I think in this particular case, it was done safely with the longest established technology, and the patient did well.
Jack, if I may, I don't want to miss the opportunity to say two things. First, I just want to underscore the work of Abreu, meaning that he was able to incorporate biopsy to target. That means that compensate, the limitation that have MRI imaging. So I would say that's the right way to go. And in relation to the urethra treatment, HIFU, at least you can treat pretty safe one side of the urethra. I don't do whole gland treatment. I don't ablate the whole urethra because I'm afraid of the stricture. But sometimes when we incorporate in the ablation limit just one side of the urethra, nothing bad happens.
I agree.
Fantastic. Thanks so much for sharing that. I think that's going to be very, very useful to our listeners. Now, I'm sure we all have a lot more comments. Let's move on to the next case so that we can hear from Dr. Peter Chiu. Just to the audience who are live, I think we have about 30 people logged in now and more coming in. Please enter your questions into the chat and I will post them to the faculty here. So, Peter, please go ahead.
Okay, thank you very much, Jack. I'd like to share one case of mine, one failure case, in fact. So, recurrence of the HIFU. So, nice to meet every one of you. Thanks for the invitation, Peter from Hong Kong here. So, this man was a 66-year-old man with good heart health, good sexual function, good general condition. Screening PSA of 6.3 and MRI at the time 39 prostate, Parrott's 4 lesion over the left anterior horn of Abreu zone. So you can see there's a tiny 5 millimeter particle lesion here. We did a targeted biopsy and systematic biopsy showing 2 Gleason 4 pattern cancer in that tiny spot. and another 3 to 3, I believe should be within 2 to 3 millimeters on the right mid at that side. This was mapped core by core, so we actually know the exact position on this organ-based tracking fusion biopsy. That was like 3.5 years ago, although it's a 4+4, the PET scan showed no obvious metastasis, and discussed with the patient. Although this is like 4+4 is like considered a high-risk case, but he's not keen for any radical treatment, and at the time he opted for like HIFU treatment. So it was done with MIR distribution guidance, and we treated actually both sides. It can be argued whether I need to treat the right side in addition to the tiny lesion on the left side. But the patient strongly requests me to treat also the other side. So at the time, I treated also the other side. So at 6 months, the MRI and 12-month MRI show no recurrence, and the PSA dropped by about 56%, which was not impressive, but the PSA stayed there for like almost like 1.5 years before it slowly crept up until a few months ago it was like 4.7, and we repeated MRI showing a new lesion over the right basal region in the transitional zone. Interestingly, we actually did targeted and systematic biopsy, but the target lesion actually showed no cancer. But however, there were 3 other locations which were not exactly in the treated region, showing tiny spots, 1 to 2 millimeters of grade group 1 cancer. So the discussion here is now is a 69-year-old man with normal sexual function, everything otherwise very well. The PSA from 6.3 baseline pre-treatment dropped to 2.5, and now slowly going up to 4.7 with diffuse group 1 disease. Should we give out active surveillance? Should we consider radical treatment, or will we even consider for this like diffuse disease reablation of some sort? I actually haven't treated this patient, and this patient actually opted for observation at this moment. But for discussion's sake, I would like to seek the opinion from the experts here to see what would you have managed this patient. Thank you very much.
So I suppose this brings up a lot of points, doesn't it? I only found 4 points to bring up in this particular case. Point 1 is, should you be treating a 4+3? Point 2 is, do you really need to treat the low volume Gleason 6 on the other side? Point 3 is, would a PSMA PET scan help you in this situation to find out whether you've got a significant tumour on the right side? Because PSMA PET scan notoriously does not light up when you've got a Gleason 6 tumour. And so really 3 major points. I think the decision as to how to manage this guy at this stage really depends on how confident you are of hitting that spot. Are you absolutely confident you've hit it, then it's a Gleason 6, or is there a possibility that it may have been missed? And only you can judge that. But I think based on the follow-up of people with a negative or an essentially negative biopsy for a PIRAD4 lesion, about 1/3 resolved, 1/3 turn out to be a higher grade lesion, and 1/3 are unchanged. So, does that mean you've got a 1/3 chance of having a higher grade lesion if one had a further targeted attempt? So my comments at the moment would be, I probably wouldn't have done the ablation on the other side, but in America, the fear of a low volume Gleason 6 in this population is very high. And a lot of the patients will want clearance of all their tumour, no matter what grade it is. That's not the case in Australia. We can sort of explain to them the Gleason 6. And I suppose I'm interested in the panel's opinion about a 4+3. Certainly, it's a common practice worldwide, and as long as it doesn't have intraduct or cribriform pathology, or it's not particularly large, it seems to be a reasonable option in a well-informed patient. So I'd be interested in the comments of the panel.
Yeah, Phil, those are really great points. I think you hit the nail on the head in this case. And I think this ties back to Andre's earlier case as well, where he treated a 4+4 with cribriform. So you've made clear your stand that you would probably exclude these cribriform tumors. Ruben, what would you think from Cleveland Clinic? You know, Phil has raised some nice considerations, depending, of course, on the patient's outlook, mindset, and all that stuff. But is there any hard stop that you would tell patients, just no way, I wouldn't treat this with focal?
Mm-hmm. We have very clear indication of focal treatment, and the normal criteria that we use is until 3+4. But don't get me wrong, from case to case, we apply what is called extended criteria, and we have done some 4+3. But I just want to underscore that I would say that the source of energy that we are using to deliver focal treatment does differentiate between killing 3+4 or killing 4+3. I would say that we have to put on the table another variables to say that this is not candidate. And I would say that 4+3 tends to be more multiple spot, tends to be more multifocal. If you find the rare patient with just unique 4+3, just for the energy perspective, I would say that the energy that you're using is going to be to ablate completely that area. I'm not the one that's going to say that I'm going to do the things better or not. But when I treat unfavorable intermediate prostate cancer, I tend to apply a margin a little more generous. And I was a little afraid when I saw the picture from Dr. Chiu that he was a little bit conservative in that area. Probably it's because the anatomy of the prostate at that time, but especially medial and anterior, probably the patient is not going to have any functional impact, but the margin is going to be wider, decreasing the risk of recurrence.
Yeah, I think that's a great point. So, Ruben, sounds like you would go for a grade dependent margin. When if you're a higher grade or you're doing extended criteria, you would probably treat with a larger margin. What would be the ballpark on these margins if anatomy is not a factor?
I mean, when I see, more higher patients, what I apply is a margin to 10, 12 millimeters, especially no outside the prostate, no near the neurovascular bundle. I cannot go to the apex, but internally to the prostate, stay away of the urethra. If I have a margin, I have an area, those patients is when I apply the extended criteria. But if I see in a patient with 4+3 and apex that I'm not going to be able to apply a generous margin, I would say that patient is going to be better served using other technique.
That's a great point. Well, we have a question from the audience, and I think this is one of the points that was raised in the earlier case, and I can see it in this case also. Well, Peter really picked up on the possible recurrence here because the PSA went back up. And we saw that in Andre's earlier case as well. So we have a question from the audience, which is that how much of a drop of PSA is considered good and successful? And then how long of an interval of monitoring before we decide if the treatment is likely not effective? Let's take the question about the PSA first. So maybe we run through the panel. Maybe Peter, Phil, and Ruben can comment. How much of a PSA drop do you expect to see and when before you tell the patient that all seems fine, we can just go on a regular monitoring?
So I'll take it first, I suppose. in our series that we recently published in the British Journal on irreversible electroporation for focal therapy with a good safety margin, on average, we got a 2-point drop in PSA. But unquestionably, PSA is the least reliable of all the indices in terms of assessing outcome. And I think you really have to have an MRI or a biopsy at some stage to find out whether it's been successful. And the other thing to be cautious about is within the first 3 months of getting a PSA, it can actually go up from the inflammatory response. So I think a PSA at earliest at 6 months can be, it's reassuring that it's gone down. If you've got a very large prostate, it might not go down quite as much.
Got it. What do the rest think?
Yeah, I think that I agree. What I counsel my patient is that we are going to see a drop of the PSA. How much? I don't know, because there is so many factors. How big is the prostate, the inflammation that is going to occur? What I'm looking for is a drop and a plateau. So I'm more interested to get some stability over the time and not an absolute number. I request the first PSA 3 months after the biopsy. I will follow the advice of Dr. Stricker, but sometimes for the patient, waiting 6 months to see how the things are going can be too much. So, but from time to time, because the inflammation that he was telling us, I see a spike. So I repeat and I don't change the management. But here, at least every 3 months for 1 year, and according to kinetics, we do an MRI, of course, with perfusion, and a biopsy between 6 months and 1 year to all the patients.
That's great. Peter, what about you?
I think, again, I think it depends on the initial prostate size and also the ablation, the percentage of prostate it's ablated by during focal therapy. So it's highly variable. And I agree that I'll take the PSA at 3 months, but as I said, it can be unreliable. But and I fully agree with Dr. Olivares that the drop and keeping it at a plateau would actually be more important than the actual percentage. But frankly speaking, if we get a high percentage of drop, say like 70-80% of drop from the baseline or more, would be a very reassuring figure, just as in Andre's case, like after the second ablation, PSA dropped to like 0.0 something, which is definitely a very reassuring sign.
I agree with that. And perhaps just for the audience, I think most of us do recommend some kind of follow-up imaging at an interval. I think Ruben has said 6 to 12 months. I do my own repeat MRIs, and I usually offer them a biopsy. I tell everyone who wants to do focal, they get rebiopsied in 12 to 18 months. That may be a little bit overdoing it, but I think we are still yet to accumulate evidence to see who can avoid these biopsies. So let's move on to the next case. We have an excellent case from Dr. Phillip Stricker. Phil, please take it away.
So this is a 69-year-old gentleman who had a clinical T2A lesion, and the PSA was 8.6. Do I have control of the slides? Yes, I do. And the PSA density was a little bit up, and his PSA had gone up from 8.6 to 10, and the PSA density relative to a 40-gram prostate was a bit high. So he did have at the left apex a Gleason 4 + 3 = 7 tumor. And this is the way our pathologist gives us the report. Again, a transperineal template using ours and Barzal's technique. And you can see here at the left apex, there was a Gleason 4 + 3, but only 50% 4, so only just there. There was no cribriform or intraduct tumor, and there was a tiny bit of low volume Gleason 6 on the other side. So in this particular case, you can see the lesion quite clearly. I think it's important to recognise on the ADC map here that it's fairly close to the midline. And you may have also noticed that this was 7 or 8 years ago when I did this. That will become relevant in a second. So we treated this, and we always do a day 2 MRI just to make sure that we haven't completely missed it. And this is just our quality control. And this is the day 2 MRI, which shows hemorrhage and but you can see that I've focused on the left apex, but I haven't really crossed the midline there. And so PSA did drop, and the MRI, the follow-up MRI at 1 year looked pretty good. There was some shrinkage of the tissue at that stage, and a transperineal biopsy at that stage was all clear. So moving forward, his PSA at this stage was 6.9, and then we moved forward, and 2 years post-treatment, his PSA went back up to 10. And so we, again, the MRI was clear, but we did a PSMA PET scan at this stage, and the PSMA PET scan showed a hot area in the left posterior apex with an SUV of 6.5. I'm sorry, at the left mid to basal area. And so what I did a targeted and template biopsy, which showed the left posterior apex adjacent to where I treated had a Gleason 8, and the right transition zone, similar to what we showed even before the original treatment, had a low volume Gleason 6. So what he had was a lesion at the extreme posterior apex adjacent to the treatment zone, and that was just medial to the previous lesion. Clearly, if you go back to the original lesion, if you would adopt the plan, which is a centimetre safety margin, which we all now know, that would have not recurred because I would have actually gone wider at that point. And so I did a redo IRE, and I'll go back, and I did a redo IRE and really went right across the whole posterior apex. And as a result of that, the PSA, let's have a look here. It came down to, hold on, so it came down to 3.7 and then 2.7, and it's remained stable that whole time, and the MRI has been clear. And I think the reason for presenting this was I was trying to go too close to the lesion initially, and I think had I gone wider, he wouldn't have needed a redo treatment. And I think the lesson I learned here was that a centimetre safety is the rule. It's based on a lot of scientific data now and radical prostatectomy data. I've managed to get out of trouble with this one, and he's been good up to date with good functional outcomes. But I presented with that in mind. We then went back and looked at all of our redos with IRE, and we found that 15 of the 26, or 58%, had a durable response from a redo. And this was including infield and outfield recurrences. So, probably with all energy sources, you've got a 50-50 chance of, recovering from that situation. But there's also a 50% chance that you won't. So the discussion at this stage is always about, whether you should opt for a whole gland therapy. In this particular gentleman, I thought there was a good chance that, based on my initial poor judgment, that he would get a good result. So he was an interesting case, and I thought that would be worth discussing.
Yeah, that was a really nice case, Phil. Thanks so much for sharing this case, because we know you have many nice cases, but it's really this kind of case that brings out the lessons. Just a question about your data. I mean, you mentioned that local control after 12 months, 58%. Are you talking about all cancers or just clinically significant prostate cancer?
So when we looked at our data and looked at the median 5-year follow-up of IRE in this group, we found that the 5-year failure-free survival, and that seems to be the common term these days. In other words, you don't have to resort to some type of whole gland therapy, of surgery or radiotherapy, was about 80% chance that you would not need whole gland therapy within 5 years of your treatment. And it's remarkable when you look at HIFU and cryo, that figure keeps coming up time and time again across all the modalities. I think most people present their results after 1 or 2 treatments, and certainly Mark Emberton and Hashamed published their long-term HIFU data, and they included 2 treatments if necessary. But it's a pretty consistent number. It's about 80% chance that you'll get a durable response. Now, if you go to the 10-year data, the drop-off is another 10%. So you're probably down to 70%. But it doesn't. But nobody really has the 15-year data yet to be able to compare it to. So are we doing a good job? I think we are. I think these people, even if they get 10 years of no whole gland therapy and no side effects from that, and we have a good salvageable option, I think it's still a reasonable thing to do. HIFU or IRE to whole gland therapy will give that answer, but that'll be in quite a bit of time.
Right. I think we have some questions from the audience. I think one question was, how do you differentiate early in-field recurrence versus incomplete ablation? And I think Phil showed so nicely that he's really rigorous doing a second-day MRI. But perhaps I'll pose this question to the other faculty about how early do you assess the in-field area, and do you think that in-field recurrences are due to incomplete ablation, or do you think that they could be due to de novo disease there? Peter, what do you think?
I think it divides into like a very early MRI after immediate after treatment, or the first MRI that we really want to look for any local recurrence. I think the very early, like within like 1 week, or like in Stricker's case, within 2 days, it's really used to look at like how well we treated patients and to reflect whether we need to learn from it and then see whether we to correlate with the recurrence in the future. In cases, in centers which there are a lot of experience, I think in outside of the clinical trial setting, sometimes it's usually not done, and it can be done like from in some cases I heard like usually 6 months, and for myself it's usually 6 months in out of trial cases to see the first MRI after the recurrence.
Thanks. Ruben, what about you? Are you doing early MRIs for all patients, or perhaps even just for patients that you're concerned about? Is that something that you do or changes your practice?
No, I mean, we have like a strict protocol to determine candidacy for focal treatment. So if I'm seeing a recurrence in the area that was treated, what is a lack of the energy, it's a lack of ablation or the lack of the good response, it's not going to be a de novo tumor there, because we're pretty confident with MRI and most of the time repeat biopsy, we know exactly what is there. So if I have an early recurrence, I would say nothing is perfect, and focal treatment is not the exception, that for any reason that I miss, for example, no good margin, calcification in the area, cyst, that I was not able to deliver a good treatment. I don't do MRI earlier, most of the time it's not easy to any radiologist to inform after focal treatment. So most of the time I do an MRI, always linked with a biopsy.
And Dr. Stricker, do you do these MRIs routinely early for quality control, like you mentioned, or is that something you did early in your series? Would it be something that you would recommend to someone who is thinking of starting a focal therapy program, that they should do this, and for how long?
Look, I think with modern techniques of targeting, and I don't think that the MRI, and I just want to clarify that it's only a T2 15-minute non-contrast MRI as a quality assurance. And it's something that I picked up from Mark Emberton. And when I was starting the program in 2013, it was something that was just another added safety thing to make sure that we weren't completely missing the area. I think the area's moved on quite a bit since then, so I don't think it's really necessary to be part of the area, part of your protocol. I think that the one area where it gives me reassurance at times, just very occasionally, you have a person who has some rectal symptoms, like a little bit of diarrhea or mucus or something. And I think having an MRI which shows no edema of the rectum is a very reassuring thing at that particular time, because we all fear fistula. And if you have no edema of the rectum, then there's certainly no fistula there. But in answer to your question, this is a quick 15-minute limited MRI to make sure that we haven't completely missed the area. And I don't think that's necessary anymore.
Right.
Jack,
you mentioned earlier about sorry, Ruben, go ahead.
No, I just want a quick question to Dr. Stricker. When you redo IRE, you change your planning, or you change the setting of energy, or you incorporate the area previously ablated plus the margin? How do you plan that?
So that's a great question. As you know, after any focal therapy, including IRE, there's a massive retraction of the area which has been ablated. So often there's very little tissue left to ablate in the area that you've actually treated. So it's a theoretical question. Obviously, what we do is we treat with a good 1 centimetre margin in that particular case on the left, on the patient's right, and we go into the scar tissue, but there isn't a lot of scar tissue to go into. So, yes, we do overlap it with the old IRE, and we use the same energy as we did before, with the same precautions with regard to rectal damage.
Perfect. I think that case is really nice and illustrates some nice points. Let's go to the last case, which is Dr. Ruben's case, and we can have more discussion after that. Ruben, please go ahead with your case.
Perfect. Thank you. Can I please have control of the slides?
I think you've got them, Ruben.
Perfect. Thank you. So this is a 60-year-old gentleman with no significant history that came from elevation of the PSA as our regular patients. The PSA was 7.5. Digital rectal exam was no suspicion, no LUTS, no family history. The AUA questionnaire showed pretty no symptom or mild symptom, and the SHIM score was 3. We tend to use ISO-PSA. If we have the opportunity, we can discuss the role of ISO-PSA that tends to measure more the physical conformation of the PSA. So it's very useful, especially with patient in the gray zone or MRI negative. In this case, the ISO-PSA was elevated. He underwent an MRI, and you can see clearly in the T2 on the right side, there you have a PIRATS 5, and the PSA density was elevated as well. The reason, after that, with that information, the patient underwent transperineal prostate biopsy that unfortunately confirmed the patient of the presence of intermediate prostate cancer with 4 out of 4 cores positive with 11 millimeters of involvement. The reason why I brought this case is just because many of our attendees probably are thinking to start a focal treatment program. And you have there all the experts in this meeting, but at the beginning we have so many questions and we are always looking for like the secret sauce in order to be successful. So I would say that if you have the opportunity to set like a focal therapy tumor board, it's a good idea. For example, in this case, you can see on the right side of your screen the diffusion weight imaging. And the diffusion weight imaging, according to the radiologists who discussed the case during our tumor board, I'm not sure if you can see clearly there, but there is a margin that goes medially. That is way more beyond that I thought just seeing the T2. I learned from there that if you go and you see what is the B value where you're going to see better the lesion is when the urine glows this completely bright white. That it's going to be the highest B value that they have to match that information. In other words, if you see the T2, you can see other faces in order to have a better orientation and try to pick what gives you more information, especially related with the margin. The other thing that I learned from this tumor board is that most of the time from the coronal view, you can get more information about the extent. For that, for example, if you are thinking in HIFU, I always try to stay away of the apex. As all of the presenter here, we do a good number of radical prostatectomy. So I try always to preserve the apical area, because if I have to go to the radical prostatectomy, I don't want to have to deal with issues about the continence. And that information, most of the time, we can get from the coronal view. So this patient underwent an eventful HIFU. The pre-treatment PSA was 4.2. 6 months after that, it drops to the half, and then it became pretty stable. It's not easy with patients with stable, and after the drop of PSA, convince them to go to the biopsy. But this patient underwent an MRI that, as I mentioned before, I tend to incorporate a good margin, especially in the area that is not going to produce any functional impact. Anteriorly, I'm always concerned of the medial anterior aspect of the ablation, because when I see failures, most of the time are in that area. It's not easy as well, but I try to get some sample of the tissue in that area, because since the patient developed a cavity that we see pretty often, I don't have tissue to sample, but I was able to try to feel with the needle where I feel more thicker tissue, and that only showed tissue necrosis. We present our experience of the building or setting a focal therapy tumor board in our institution at Cleveland Clinic is different from the general GU oncological group, because we try to learn of each other. I would say that after being doing this, the tumor board for 2 years, it's beneficial, because if you speak louder, probably your recommendation is gonna be more. It's going to be more highly likely that it's going to be accepted. But when you have a board, the medical, the uroradiology, the pathologist, and of course the urologist, the radio-oncologists go to that meeting, so we can discuss. Since it's localized prostate cancer, the medical oncology rarely go, and we always review the pathology. If the biopsy was performed in an outside facility, we review here with our pathologist, and also the MRI. This is the cohort after 6 months that we were doing this, and just want to highlight that 70% of the patient that was presented was deemed no candidate for focal treatment, and we offer most of the time or active surveillance or whole gland treatment. The main reason, for example, in this cohort thinking in HIFU, is that the lesion was crossing above the urethra. So we don't want to spend we don't want to deliver the energy about the urethra because the risk of damage. And also when there is a risk of ECE. Just to show you that line should be perfectly perfect, meaning that when the patient came with an MRI label of Pyrax 1, we are hoping that our radiologist is going to agree with that. Unfortunately, that match was not pretty frequent, and from time to time we see patients with that coming with an MRI reported as Pyrax 1, when in reality was reported as a Pyrax 5. In terms of the pathology review, almost 20% of the patient was downgraded to grade group 1. We are always concerned with just one core positive or grade group 2, so that patient is going to be better served as active surveillance. So in conclusion, I think it's important to have the opportunity to review the new cases and also review the cases already performed in a transparent way when we can show the PSA, the MRI, and that sort of things. And in this cohort of the patient that produce a change is almost 70% of our patients.
Thanks, Ruben. That was a really great case and illustration of how you do your tumor board. Normally I don't like having the didactic slides in the FTS tumor boards because it's more about the case discussion, but I thought that this was a really good point for the learners and beginners to look at. And, Ruben has done a lot of work on multidisciplinary tumor boards. But I just want to ask the panel, I guess we all started off with support from our colleagues in different ways. Obviously, we work a lot with our radiologists. Do you guys present your cases at a tumor board? And if so, do you use a regular GU oncology tumor board? Do you always have a radiation oncologist involved? When I started this off, I did it for my phase 2 trial, which is how I started focal therapy. So I did have a pathologist and a radiologist, but I did not necessarily have a radiation oncologist on board. Perhaps I should do so. What do you guys think? Andre, Peter, Phil?
Yeah, so this is a very good question. I think that if you are establishing your program, it's a very good way to do. But not only this, have other colleagues that have experience in focal therapy to participate as well. Get educated, get colleagues involved, and reach out to anybody that you think that can help you in the focal therapy. Focal Therapy Society is there for this. One of the reasons is to help out one another. Yes, I did focal therapy tumor board from the very beginning. That was tumor board only. Then went to GU tumor board. And after 7 years that we are doing now, things are more settled down. And we don't feel the need to do unless it's some special case. But I totally agree that is a very good way to get started.
Peter, what about you?
I've on and off these meetings with the radiologist to look at the cases, like particularly after after treatment. We don't have it very regularly, but for difficult cases or suspicious cases, they want to discuss. We actually discuss with the radiologist and the pathologist. For the issue of whether should have a radiation oncologist there. I do not have it, and I'm a little cautious because whenever my radiation oncologists are there, they say they're very inclined, to do the radiation, and it's not. Sometimes it's like a multidisciplinary meeting instead of really a focal therapy tumor board. So I didn't put them into the meeting. But I would like to seek your view too. Would that be a difficult situation for you, Dr. Olivares? Yeah.
So, Ruben, I think you're to be commended on always having a tumor board. I've been the chairman of that board for the last 20 years. And at the tumor board, we have all the components that you had and recommended. But even outside of a tumor board, if you can't put that group together, I think you made two excellent points, and one is getting the histology reviewed, and one is getting all the imaging reviewed, because we all have experiences where the tumor is downgraded or indeed upgraded, and we all have experiences with the overcalling of MRI lesions and the undercalling of it, and so I think it's essential that we do that. I think having a radiation oncologist, I think, is really important, because I think that they're one of the standards of care, and I think they should be part of that group. We also have a nuclear medicine physician involved, since PSMA PET scanning has become a common thing, and they always sit in the group as well. So I think that anybody starting a program should absolutely have all those people reviewing it, because it's surprising how many times you learn from that group.
Yeah, I think that's a really good point. And sometimes I put up a case, and then my radiologist says, look at this tumor. How could you put this up? It's extending well beyond what's acceptable. And my pathologist would chime in and say, hey, I upgraded half the course from 3+3 to 3+4. So, they really hold me back and make sure that our series has good results. I think the other thing is that it's good to include the radiation oncologist, and I think both Phil and Ruben, what you guys have said is really inspiring, because I think it teaches the whole team. I mean, the radiation oncologist sits in, and they too learn, what cases succeed and which ones fail, and they would recommend focal to some of their own patients, hopefully, like what they're doing with active surveillance now. I mean, we have some radiation oncologists who are, keen to do active surveillance for patients.
And if I may, really quick, and the other thing that we can find the how useful is this instant from many angles. From time to time in our clinical practice, we see patients with low volume prostate cancer, a few spots of grade 1 prostate cancer, really interested and pushing to get focal treatment. We can discuss further, but I would say that focal treatment must not be delivered with low-grade prostate cancer patients. So if we tell the patient, okay, we're going to present the board, and the recommendation was advised against focal treatment, I think we have an extra support.
Yeah.
Very good point. So I think there are always more points to discuss, but I think we've reached the end of our session. We're 2 minutes over time, and I want to be respectful to everyone's time. So I think we are going to close the session for the live audience. I really thank you for joining us, and I think we are also grateful to our esteemed and distinguished faculty. I think if you have any questions or you want to watch the video again, this video is going to be posted on the Focal Therapy Society website. So please complete the survey form. I think this is going to be very useful for us to improve this session. And, we are trying to do this session every quarterly or every 4 months. So look out for our next announcement on Twitter and social media. Thank you so much. I think we can go off air now. And I'll ask the faculty to just stay back for 30 seconds. We can take a group photo together.